Two speakers, Jett and Christine Berg, and I'm just going to introduce them briefly and then let them speak. So Jett is the director of the Clinical and Translational Research at the National Jewish Health in Denver. He was the former editor-in-chief of the ISLC Journal, the Journal of Thoracic Oncology. Dr. Christine Berg is an adjunct research professor at George Mason University, and she is the former National Cancer Institute lead investigator of the National Lung Screening Trial, which was really a critical trial that changed what we do in screening for lung cancer. So with that, I'll ask Jim and Christine to speak.
Thank you. And the third member of the team, Dr. Henschke, has one of the top abstracts presented at the meeting. So all three of us are going to cover the screening aspect. My job is to set the stage for you. It's a huge problem, and again, I know the physicians here are very familiar with it, but maybe the press is not quite as familiar with it. But according to the World Health Statistics, it's estimated there's about 1.4 million deaths from lung cancer. In Australia, there's about 8,000 deaths per year from this disease. A few more men than women, but both genders account for the deaths there. It accounts for about 19% of all cancer deaths in this country. And in the U.S., it's even a bigger problem. 200,000 new cases per year, 160,000 deaths. 48% of all cancers are now in lung cancers are in women. When I was in medical school, it was 7 or 8 to 1 cancers men to women. But now the women have, unfortunately, in this case, achieved equality. They want equality in many areas, but I don't think they wanted to die like the men. So that's a huge problem. And again, it's estimated there's close to 400,000 survivors from this disease in the U.S. The problem is the global estimates are that 86% of all people who get lung cancer die from lung cancer. So that's the problem. There are no symptoms of early stage disease, and lung cancer was not considered a tumor that you screened for. But I think that has now changed with the recent landscape, and that's why my two co-participants are up here to tell us about this. Dr. Berg was co-chair of the NLST, the big screening trial in the U.S. That showed some advantages. I'll let her comment about that. And Dr. Henschke has been one of the main champions and early adopters of low-dose CT. She helped to push the whole field forward. So that's kind of where we are at this point in time. And Christine, if you want to make the first comments, and then Claudia next.
Thank you very much, Jim. It's an honor to be able to speak before you today. I am going to just give a brief, what I call a Berg's eye perspective on lung cancer screening. And I presented this morning our updated work from the National Lung Screening Trial, and which I'll briefly review, and then wanted to draw to your attention some of the presentations that were made this morning in the session I just came from, and will be discussed this afternoon. I first want to compliment my colleague, Dr. Henschke. She was one of the seminal investigators back in 1999. Her landmark paper came out in July in The Lancet, and Dr. Klausner called. He was the head of the NCI at the time, and he called me on my vacation at the beach and wanted to know what I was doing to help study Dr. Henschke's work further. So I'd like to say she's a seminal individual, and I look forward to hearing what she has to say. With the 20% mortality reduction that we showed in the National Lung Screening Trial, we proved that we can lower lung cancer mortality with a screening test. The problems are multiple, however. One is the false positive rate. We showed a 24% false positive rate in the National Lung Screening Trial. We used a threshold of 4 or more millimeters in size. And while I think it's important to have a generous capture of nodules, you really need to make sure you're not subjecting a lot of individuals to unnecessary evaluation with either diagnostic imaging tests, which is where you have a high radiation exposure, such as particularly PET CTs, which are can be 18 millisieverts, whole body exposure, which is problematic. The second would be the costs of those follow-up procedures. Some of the work being presented at this meeting looks at volumetric analysis, computer-aided detection. I think those will help lower our invasive procedures needed to evaluate positives. I also think nodule management protocols incorporating underlying demographics, like the paper Annette McWilliams just published in the New England Journal of Medicine that Martin Tamamagi will briefly mention and I'll discuss again tomorrow, I think are really critically important in moving forward the field on the false positives. Another issue is cost effectiveness. I'll be presenting our NLST CEA results tomorrow morning. This will be the first public presentation of that, and I think that data, although from a randomized trial, it will be useful, but I think the major issue is going to be countrywide in terms of deployment of public health resources. We all have issues in our countries about persistent levels of smoking, and I think those persistent levels of smoking need to be addressed first. And with children of my own, I really think what we need to be focusing primarily on is preventing young people, both young boys and young girls, from starting to smoke, and that's where I want to focus efforts as well. So now I'd like to turn the podium over to Dr. Henschke and to hear what she's going to be discussing.
Well, thank you. You gave a perfect introduction because it's the process of screening that really is critical. Let's see. So I'm going to present our abstract that we're presenting, and the purpose of our study was really to compare screen-diagnosed cases of lung cancer in a study where there was an explicit regimen of screening, or that whole process of screening, versus one that said in its mandated no specific diagnostic evaluation. So it's ILCAP versus the NLST CT arm. We considered the key prognostic indicators, stage 1 and small tumor size, and that's been demonstrated by the SEER data that size is important. And the IASLC staging criteria have divided stage 1 into multiple size criteria, so they recognize the importance of that as well. So we wanted to determine the distribution by size and stage in ILCAP and NLST. We report typically clinical stage because it's not influenced by the frequency of surgery, but most studies report what I would say a mixed stage distribution, pathology if resected, otherwise clinical, but this result is dependent on the frequency of surgery, so we report both here. So in ILCAP, we had 799 cases diagnosed under screening, of which 11 or 1.4% were interim diagnoses. In other words, found by symptoms, not recognized by screening, but found by symptoms before the next screening. Compared with the NLST had 693 cases diagnosed under screening. We're not talking about the ones that were diagnosed once screening stopped. And they had a slightly higher interim diagnoses. So concentrating on those screen diagnoses, those 788 in ILCAP, 649 in NLST, you see that on average, the size in ILCAP was smaller, 15 versus 21. The clinical stage was higher, but the problem is that the NLST didn't report this because I think they just reported the pathology here. So the clinical stage we shouldn't really focus on. But surgical resections were more frequent in ILCAP than the NLST. Mixed stage, the mixed stage of pathology, if resected, clinical otherwise, was 73% compared to 63% in NLST, and the 5-year survival rate, because the NLST really does not have long enough follow-up to look at the cure rate. So we used 5-year survival rates was 83% versus the 63%. Now, other reported studies also used a regimen of screening, and that's the Nelson, which had a very similar result of that mixed stage as we did, 71%. And in Japan, in particular, 2 studies at Baisone and Bainawa, both had a more than 80% in stage 1 and a higher and more than 80% of a long-term survival rate. So what are the possible reasons? Well, I think the acquisition and the CT scans were, in both studies, used very good scanners and experienced radiologists. We looked at the cell types. They were not significantly different. The NLST had an older cohort, 55 and older with at least 30-pack years of smoking. ILCAP enrolls people 40 and older, smokers or never smokers. And so we looked at the subcohort in ILCAP that met the same NLST criteria, and it reduced the mixed stage from 73 to 71%, but that was still significantly different. So were the definitions of size and mixed stage different? Well, the size, we used both the length and the width, the average of the length and the width, because both of those were reported in the database, in the NLST database. The staging definitions were the same, except in ILCAP, if you have multiple adenocarcinomas with no lymph node metastases, we classify them as stage 1. And I think under the new recommendations and the new work by Travis, most of those additional cancers are adenocarcinoma in situ. But if you said, let's take all of those multiple cases and not consider them as stage 1, then it would reduce it from, in ILCAP, from 73 to 69%. But that still is significantly different. And then those differences in size and stage lead to higher survival rates. So in conclusion, we really feel, and that's what Dr. Berg was also saying, that the benefit of screening is provided by the initial, not only by that initial test, that initial CT, but it's the entire process of how you go through the diagnostic workup, how quickly you get to the therapy, and how many people you don't do unnecessary procedures on. So that's all encompassed in the regimen of screening, how you get the images, what the diagnostic workup and timing is, what the therapy and timing is, and it needs to be regularly updated. So any person setting up a screening program really has to put into effect a process of constant updating. It's well known for mammography screening. By not doing that initially, they set back screening for breast cancer by 20 years or so because they had too high a radiation dose and so on. And it required Congress to pass a law that regulates that. So I think we should be proactive within the IASLC. We should really determine what are the critical performance measures, and this should be done in all screening programs. Thank you.
Great, and so now we have time for questions, and I'd like to just remind everyone, if you have a cell phone, please turn that off, and then there are questions, microphones in the back. Oh, and we also have one for walking around. You can certainly comment.
May I make a comment while
Please.
we're waiting for questions? I'd like to point out that ISLEC is to be complimented for setting up a strategic steering advisory committee under the direction of John Field. We had a committee meeting where Dr. Henschke's colleague, Dr. Yankelevitz, joined us, and the issues on the table there that are being investigated include a number of the ones that both I and Dr. Henschke have mentioned. One is a quantitative imaging biomarker assessment being done with all of the major equipment manufacturers to help set parameters for quality or technological capabilities for the imaging. I think this will help if Congress ever does get around to helping to set standards. I think this KIBA initiative that ISLEC is participating in will help with the technological imaging assessment, and then also an indeterminate nodule group, and some issues regarding management of nodules. So and surgical intervention. So ISLIC is, I think, at the forefront of helping to set up these standards. I think our goal for all of us is to optimize the screening process and to ensure the highest yield of early stage lung cancers where we can affect the best impact on mortality.
Also in the room are several of our Danish and colleagues from the Nelson trial, also the other big randomized trial, which is low-dose CT versus observation or standard care, whereas the NLST trial was low-dose CT versus chest x-ray. But our colleagues I see in the room there, they have a lot of experience with that. The Nelson trial is still ongoing.
For many screening tests, people look in many countries at cost per year life gained.
Mm-hmm.
When will we see data, and does anybody want to comment on cost per year life gained?
I'm presenting the NLST cost effectiveness analysis tomorrow morning at 7 a.m. So I welcome you to prop me up and hand me my coffee. So I presented the overall estimate from the cost effectiveness analysis and from NLST is $67,000. The incremental cost effectiveness per quality adjusted life year. I'll present more details tomorrow. The paper is written, it's been submitted, and it's under review, so we'll have that information. There was a results from the Canadian group, the PanCan study, that were just presented. Sonia is presented from PanCan, and they have a somewhat different range. Costs are a little less, as you might expect, in Canada than they are in the U.S. And then there was, so I think those data are now emerging.
So Fred Hirsch, so ISLC is an international organization. The I stands for international. And I know in United States there has been recommendation from the U.S. Prevention Task Force, I think is name. Mm-hmm. But are we on this stage ready to implement and recommend any staging strategies more globally? There are certainly areas which need it even more than others. Mm-hmm. What can ISLC on this stage do for disseminate knowledge and eventual practice aspects?
Well, I think the ISLC can do a lot because it has that international forum, and by putting out best practices and by having regular meetings, which you have all the time, and disseminating that information. So it can have a key role in doing it because it does require a lot of education of physicians, of pulmonologists, of the internal medicine and the surgeons as well. So there needs to be education of all the physician groups and the people coming for the screening. They also need to understand the pros and cons and the negatives and the positives. So I think the ISLC can do a lot.
I think a lot of people are waiting also for the Nelson trial, how that comes in. I can't speak for my European colleagues, but that's what I hear through the discussions, is that they're waiting for these trials to come in to see if it's similar in in Europe as what it is in the U.S. And then I polled one of my colleagues from Japan, and they said, well, a lot of institutions in Japan are doing low-dose CT screening. The Ministry of Health has not necessarily endorsed this countrywide. So I think a number of places are still waiting. So it would be hard for, as an international group, for us to come out and say, do it or don't do it, because countries are evolving a little differently.
But what you could say, if you do it,
yeah.
If you do it, then here's how you should do it. And, you know, there's not going to ever be another study that's as big as the NLST. And you can combine them any which way. It really showed a mortality reduction. So
Two points. One, Claudia's study was international, and it did have an excellent group in Japan that contributed information. And secondly, from our working group over the weekend, our Asian colleagues presented questions about the differences in risk factors in various Asian populations, such as unfortunate high levels of air pollution in certain Chinese cities, methods of cooking in homes with high-intensity heat oil products. I think one thing that can be done by ISLAC and in collaboration is looking at these various risk factors in a variety of different population groups, because I think the epidemiology in Japan is different from that in Korea and from areas in mainland China or Thailand or et cetera. And I think larger databases to understand the risk factors, to understand lung cancer in non-smoking Japanese women, which was a common finding. I really think we need better, larger data sets to develop enhanced risk models before we embark on wider, lung cancer screening programs. I think we need to understand the risk profile even better.
Thank you. All right, we're going to move on now to our next panel. If there's still questions, we can certainly have